Hello and good day. I'm Dr. Eddie Saul and I am the director of the Concussion Group. We're a collaboration between Doctors Imaging, doing the MRI, and the Mindset Neuroscientific Group, doing our analytics. Today we'll be discussing diffusion tensor imaging and how it can help you and your client. Today, we'll be talking about concussion imaging, but more accurately, post-concussion syndromes, the problems that you'll see when clients come to you seeking your help. Let's start by listening to attorney Jim Dodson, a trial lawyer from Clearwater, Florida.
Hi, I'm attorney Jim Dodson. When someone has a suspected brain injury, it's not uncommon for an MRI to be ordered. When you get into MRI testings, there's a number of different tests that doctors have a choice of ordering, depending on what they suspect may be going on. It is very common for a standard MRI in a brain injury context to come back normal. That doesn't necessarily mean that there is no brain injury. After a normal MRI, the doctor can consider any number of more specific MRI tests to find certain areas of damage. One of the ones would be a diffusion tensor imaging MRI, or DTI, or what we call a diffusion MRI. This is really designed to examine the water or fluid pathways in the white matter of the brain, which are the deeper tissues of the brain, which are sort of the connecting pathways between areas of the brain. So what happens so many times is a person may have been involved in some type of an accident. They have some symptoms such as memory loss, motor coordination, word finding, whatever the symptoms may be. The doctor's looking for an explanation of what's going on. This diffusion MRI many times will reveal indirectly damage to the neurons or axons of the brain affecting that particular part of the person's motor coordination, speech or what have you. And they are a very important component in the process used by the physicians to identify, detect, and recommend treatment for someone who suffered a significant brain injury.
The Concussion Group has done over 400 patients utilizing quantitative DTI. We'd like you to keep in mind some very important things. First, most clients have negative routine MRI and CT studies. And many of your clients were just dazed without ever having become unconscious. We also know that many clients will have developed delayed signs and symptoms in the days, weeks, or months after the accident. Now, I'd like you to look at these pictures. One is a fracture of the humerus, easily seen. The other is a chest x-ray that shows pneumonia, very clear again. Both require visual analysis and interpretation by a radiologist. Remember, he's looking at pictures. Here's another picture. It's a CT picture. The radiologist, or the neuroradiologist in this case, is still interpreting a picture. And this one shows a tumor in the back of the brain. Here's one more picture. It's a tractography diffusion tensor imaging, DTI. Neuroradiologists use tractography to look at pictures and help plan surgery for tumors, abscesses, and other brain abnormalities. But remember, the radiologist is still looking at a picture. Here you can see how the tracts may be displaced by a mass in the brain. Again, looking at the picture. So what I'm demonstrating here is that we do not do pictures. We do quantitative analysis and data. We'll be examining 48 regions of the brain, and we won't be wishy-washy. We'll be telling you that we are 95% certain that a particular or multiple particular areas of the brain are abnormal. And we'll be able to back that up with science. So remember, we don't do pictures, we do data. So today we're here to talk about brain injuries, concussion, particularly post-concussion syndromes. We'll be using diffusion tensor imaging, and we'll be dealing with data, which makes it quantitative and objective. So the concussion group is composed of DTI specialists. That's what we do. Some of your clients may have been involved as victims of an explosion. They may have been in the explosion, near the explosion, or even far away from the blast. Nevertheless, they may have experienced brain damage and concussion, and they may have a post-concussion syndrome. We have seen a few clients who have sustained injuries to the brain that were involved with railroad accidents, one of whom was a passenger and the others that were workers. In the last few years, people have been very concerned about athletic injuries. That ranges from high school football players through the NFL and professional athletes as well in soccer. These injuries occur as a result of training and practice as much as the day of the event itself. Most of the patients that we see will have experienced a motor vehicle or an industrial accident. Take a moment to study this slide. You'll see there's lots of signs and symptoms. Initially, your client may have been just dazed, not really unconscious. But remember that some of these signs and symptoms may become evident many days, weeks, months, or even years after the incident. Most clients with concussion will have resolution in about a month, but you'll probably be seeing them from 2 to 6 months after their injury. So be alert to the following. Your client may have changes in sleep pattern, or may have amnesia or forgetfulness. They may complain that they just don't feel right, or that they have fatigue or loss of energy. They may be sad or even depressed. Many will have anxiety and many will have memory problems. And they'll have an inability to concentrate or do routine tasks at home, work, or at school. That's called executive dysfunction, and it's serious. So why do we perform DTI? Well, DTI interrogates the white matter of the brain, in particular the microstructure, and that's the most important location of pathology. And DTI differentiates patients who have traumatic brain injury from those of normal controls, and this can be seen years after the injury. So let's talk about axonal injury. This is an axon, and there's actually billions of them in the brain. So let's take a cut through the brain and show you a pathway from one area to another. Well, there's millions of axons along this one pathway, and we will be looking at all of the different tracts of the brain that are important to us in terms of cognitive function, memory, and other abnormalities that occur after an injury. So remember, again, that we're looking at the axon, and what we're looking for is axonal injury. And here's how it works. This is an axon, and if you focus on the yellow area, it's basically the conducting portion of the axon itself, sort of like an electrical wire, if you will. And wires have insulation, and this area here also, this yellow area of the axon, is insulated with what they call myelin. It's a myelin sheath. So it's important to remember that these are cells of the body, and they have an insulation around them called myelin. So the procedure is as follows. Naturally, we put the patient in the MRI machine and we scan. And in the scan, we'll get routine MRI studies that produce these black and white pictures, the three on the left. But in addition, we're going to do DTI studies that produce tractography, which we don't use for interpretation, but that's what gives us our data that we will analyze. So again, we have three pictures on the left and the tractography on the right, which we then evaluate the data. So what will we be analyzing? Well, we'll be looking at that axon that I showed you earlier, and we'll be looking at the path of the water molecules as they move across the axon, which is insulated. And we'll scan 48 regions of the brain, which have been defined by Johns Hopkins University, in order to see all of the white matter tracts that are important to cognitive function. And we do this in order to determine whether there is nerve damage or axonal injury. What we do is evaluate what is scientifically called fractional anisotropy, or FA. So remember the term FA. So the main term that we are using is diffusion. That's the first word of diffusion tensor imaging. I'll explain it to you by showing you how a drop of ink into water diffuses. You can all see this right in front of you right now. That's diffusion. And it's random. So the diffusion that I just showed you in that flask of water is very much like this round cell where the diffusion is very random in all kinds of directions, actually an infinite number of directions. What we're looking at is the axon, which is on your right here, and it is linear and it's directional. So that myelin sheath that I told you about, the axon, keeps the water moving in a certain direction, or the water molecules, and that allows us something that we can measure with diffusion tensor imaging. Let me give you an example. In the last slide, I showed you how the axon basically allows the water molecules to move in a certain direction. But for a moment, think of a copper wire with insulation around it, and the multiple wires that are in a fuse box or any electrical connection. The copper wire moves electricity. Well, the axon moves water molecules in one direction, and the myelin sheath makes it go in that direction, divorced from all of the others around it. So it's protected in that direction. So you need to have insulation from the myelin, which can get damaged. So if you think of it as the electrical circuits of the brain, and you think of all the different connections going in different directions with different colors, you get some idea about what we're studying with diffusion tensor imaging. I know it's complicated, but this is the simplest way to think about it. So to reinforce what I told you about in the last slide, you have to think of the brain as a compact, complicated electrical junction box with wires going from front to back, right to left, up and down. And while wires require plastic and other materials as insulation, these tracks in the brain with water molecules require a myelin protection for each of the directions so that there's no short circuits. And we know what the short circuits do. They give you cognitive problems and memory problems and personality changes. That's the easiest way I know of to allow you to think about how the brain works. As we evaluate your client, who may have all types of signs and symptoms in a post-concussion syndrome, we'll be looking into the brain to see what it is that is abnormal, where the axonal injuries might be. In doing so, we'll be discussing two terms frequently. The first is fractional anisotropy, or FA. Remember that term, FA, because it may be high, it may be low. And the second is a z-score. The z-score is simply how much that value deviates from our normal control group. So FA and z-score will be the terms that we need for you to remember as we go further in this presentation. So what is a normal FA or fractional anisotropy? Well, you may recall that I had you compare the movement of water molecules in certain pathways in the brain, similar to what might be electrical current going through a wire that has all types of insulation. So when normal FA is occurring in the brain, it's much like this highway picture, where the cars are moving along, everything's good, people are on cruise control. It's smooth highway driving, no interruptions, everything's really cool. So what happens when that normal traffic pattern is interrupted by an accident? Well, people slow down, and that's what happens in the brain when you have an axonal injury. The FA gets low. The water molecules start to move more slowly or may even stop. So you have to remember that this is, again, like the electrical pathway. And if there's a short circuit and the insulation gets bad, you're likely to have your lights go off or your radio stop playing or your TV go haywire. Well, in the brain, if there's an injury to the axon, it's going to interrupt the water molecule from flowing. It's going to mess up the connection, and well, things are going to slow down, and there's going to be clinical symptoms that go with it. In order to do quantitative DTI, or quantitative diffusion tensor imaging, we require advanced high-field MRI technology. So we use only 3.0 Tesla MRI when we do our studies. As an attorney, what will be most important to you is our report. I will be happy to send you a redacted paper copy of the report, or you can go to our website, www.theconcussiongroup.com, and see what the actual report looks like. But let me review what it is so you'll have some idea as to what it may mean to you. We start with a background, and this is a 34-year-old female who self-reports involvement in a motor vehicle accident in February of 2017 without loss of consciousness. And currently, she self-reports numerous symptoms, including headaches, memory problems, behavior and personality changes, and fatigue. She particularly mentions difficulties with multitasking, concentration, anger control, and transposing numbers. So, the other technical details you could see here are not really that important to read, but the FA values we're deriving are from 48 different fiber tracks. Now I'll explain to you the graphics that we also submit in the report on these 2 pages. First, note that we have 106 matched controlled data sets that we've identified for a control group. That's out of approximately 1,500 that we have available. So we have the largest control group available. And you'll note that our findings in this particular patient showed abnormally low FA to a degree of 95% certainty in values 9 out of the 48 tracks that we measured. That's considerable. And if you look over to the right, you'll see that there are graphs. You'll see the bar graph, which has left side and right side. That's the 48 regions. There's 24 on each side. If those areas are gray, they're within normal range, within 2 standard deviations, essentially, of the normal. But if you see a blue, a light blue, it's going to mean that it's abnormal, slightly abnormal. A darker blue, moderately abnormal. And of course, the very dark blue, which is really abnormal. And then we test them, and we basically report that track number 3 or 16 or whatever it is, down to 45 and 46 are the abnormal tracks. The name of those tracks, according to the Johns Hopkins University Atlas, and then what those tracks are known to control on the basis of the research at Johns Hopkins University. So, it's important to know that all these fiber tracks individually are identified as abnormal, are still considered to be abnormal after a correction factor, that's a statistical factor, for multiple comparisons. That may be too much for you to really want to understand. All I can tell you is that there's a lot of statistical significance that's basically unchallengeable when we go through all of these particular metrics. So remember, Left side, right side, 24 regions on each side. We're looking at all the regions, many of which are gray and normal. However, there are many that are abnormal here, and they are abnormal with low FA. So I'm going to show you a couple of what that might look like when you have a picture of the brain. So in the report that we give you on your patient, you'll get a picture similar to what we're doing for this sample patient. We will have noted that tract 3 was abnormal, and that tract 3 is the genu of the corpus callosum as defined by Johns Hopkins University in their atlas and their research. And what does it connect? The left and right brain in the frontal region. And what's its function? It's the coordination of executive functions between the two sides of the brain. That's very important to your neurologist or your neuropsychologist or any other doctor that's involved in the evaluation of your client. Similar to the last slide, tracts 45 and tracts 46 were reported as abnormal. That's the left and right uncinate fasciculus. What do? They connect the hippocampus and the amygdala to the orbital frontal cortex. What's it involved with? What's its function? Again, according to the Johns Hopkins University Atlas, it's involved with memory and emotional processing. So that'll help you when you present your case regarding what area of the brain is involved, and it certainly will again help your clinicians that are working with you to help your client. So now that we've looked at the graphs, what's the meat of the coconut? What do you really have to derive from our evaluation? Well, first we're going to say the FA values were abnormally low for 9 individually measured fiber tract regions. And then there's an issue that's more statistical that we evaluate, and that's the issue of multiple regions. And to address this issue, the data were additionally evaluated using the Benjamini-Hochberg correction for multiple comparisons, which basically says, in this particular case, the FA values after this evaluation were considered to be statistically abnormal for all 9 regions. What's the conclusion? It's an abnormal DTI evaluation with significantly low FA values in multiple fibers, even after correction for the multiple comparisons. That's a lot of statistical stuff in there, but basically we're saying we're 95% sure that this is an abnormal examination in each of those tracts that we described. And of course, this has to be compared to the patient's clinical findings, whether it's from your neurologist, your neuropsychologist, or any other doctor that's involved. So essentially, we're saying we're giving the doctors that you use or that we may help you to find, we're giving them the data to correlate, okay, with their clinical findings and to make them more meaningful for you as you proceed with your case and, of course, for the client that you're trying to help. Who signs off on this? Dr. David Lewine, who's our principal neuroscientific consultant at the Mindset Group out in the University of New Mexico. And, of course, I will be involved as well in the signing off of this as the MD that oversees the entire operation, so we'll go there as well. Now, I've already reviewed with you the findings and the impression and the conclusion and the sign-off, but I wanted you to also see this graph with the FA values and the Z-scores. So the Z-scores I've highlighted there are what the score is, how many standard deviations below the control group is involved within zone 3, 45, and 46, as I've already discussed with you. So that's where the Z-score comes in. It really just follows the rest of the examination, and it's basically a measure of the standard deviations between the client and the database of the control group, and what that standard deviation has been calculated and how many it is the Z-score. Not all that complicated, but just another page in the report. As an additional part of the report, redacted, there'll also be my doctor's imaging report, which basically says how we do everything, what we did, who was involved. Also, it has in there the SWI report, which is susceptibility, which is one of the sequences that we do to make sure there's no hemorrhage being overlooked. And then, of course, I repeat the findings of the areas that are involved, and I come to the same conclusions pretty much in this particular case as the group in New Mexico from Mindset. And I basically cite some of the literature that supports what we do, whether it's low FA or high FA, but I sign off of it so that I become the principal that's involved in any litigation with depositions, trials, and I'm the one that kind of guides the process in terms of helping the attorney develop the case. And of course, we have our group at Mindset with 2 attorneys there that have a lot of forensic experience with respect to DTI that can be of help to anybody that would like to be directed in their approach to a particular client and their injury. What does statistically significant mean? Is the high or low FA that we see real, or is it a chance random finding? What do we mean by chance? We challenge all of our 48 regions results individually. Because we use low probability as a reason to reject the finding, you might say we also mean what's our chance of being wrong, and that's a false positive. So we set our levels as less than 5% at a time, p less than 0.05. That's our level of confidence regarding a false positive. So the size of the control group establishes the reliability. Now we extract age and gender-specific controls from a group of over 1,500. So for most patients, we'll have anywhere between 40 and 100 sample controls. And the more of the 48 regions we test as being positive, the greater the level of confidence. So now let's try to wrap this up by getting an overall concept of what it is that we do. You have evidence of a brain injury. You know the history of it as the attorney. You know when it happened, how it happened, where it happened, and you've already consulted with a physician who may have certain findings that he believes are abnormal in terms of the patient's behavior, your client's behavior, their cognitive and their mental status. That's all important, but it really doesn't mean a lot to us as we do our DTI evaluations because we're totally objective, independent of what the history is. We don't ask the patient for history. We just get it as a matter of documentation. And we basically do our analytics and provide you the data with 95% certainty. That's the data that you and the treating physicians need to be able to correlate what's going on with this patient to what we're seeing in the brain. So that's where DTI has its value. It's extremely effective, and we expect that it will provide important information regarding what it is that's causing your client to have such difficulty. So once again, I stress the fact that we are objective and not subjective. And the concussion group uses quantitative DTI, and it's data-driven and, again, completely objective. Why the concussion group? Well, we bring to the table a lot of courtroom experience, 4 years of using quantitative DTI with multiple depositions and trials, and we're here to help you get through that process and to do it effectively as the data demands. We also are available for trial planning assistance either here locally or with our Mindset group where we have 2 forensic attorneys who are quite adept at head trauma and DTI evaluations. And we have credible expert testimony between Dr. Lewine, Dr. Silvestri, myself, as we deliver those results to you in a compact report that is basically a guide to how you might want to proceed with your litigation. The concussion group can save you money. We only need your client for approximately 1 hour, and even if they travel from afar, they frequently can return to their hometown the very same day. Then they can see the neurologist or the neuropsychologist of your choice conveniently in their own community, without repetitive trips or need for overnight stay. Or, if you prefer, you can consult with Dr. Ann Foundis, our cognitive neurologist. The concussion group is here to help you. How do we do that? Well, we have friendly service, and it's easy to schedule. You have direct access to me at any time, as well as our staff, and you'll get comprehensive reports. The sample of which I think I mentioned earlier you can get online, or we can send it to you in a printed fashion. You'll get quick turnaround. It takes us about 2 weeks from the time we do the scan on your client. And it's very easy to schedule trials, depositions, and conferences. They're easy to arrange, and we really adapt our schedules to make it comfortable for you and any of the other attorneys that may be involved on either side of the case. There's a huge amount of literature that's available, and if you go to our website, you'll find that you have access to multiple articles about diffusion tensor imaging and traumatic brain injury. But I show you this one because it was published in June 2016 and it's comprehensive. It's entitled MR Imaging Applications in Mild Traumatic Brain Injury, and it's an imaging update. The bottom line is, once again, the consensus is that DTI effectively differentiates patients with traumatic brain injury from controls. That's exactly what we do, regardless of the severity and the time frame following the injury. So bear that in mind, and please feel free to go look at the extensive literature that we have on our website. Who's involved in our concussion group? Well, I am the director, yours truly, Edward L. Sala, MD, and online you'll be able to find my CV. I do the initial attorney consultations, and the data and reporting, I supervise all of that, as well as I'm the principal litigation participant, and I control the quality of our programs. Critical to our work is Dr. Jeffrey Lewine, who's a translational neuroscientist, and he's the director of the Mindset Research Group at the University of New Mexico. He's our principal neuroscientific consultant. If you'd like to see his CV, just request and I'll be glad to send it to you. Next is Dr. David Silvestri. David's a radiologist, and he's the medical director at Doctors Imaging. He does brain MRI evaluation and structural reporting, as well as DTI consultation. Dr. Ann Foundis is part of our collaborative group, and she is a cognitive neurologist. She serves as executive director for the Brain Institute of Louisiana, and also is a research professor at the Louisiana State University School of Medicine. She's the managing partner of New Orleans, Louisiana Brain and Behavior Group. David Robinson is a registered technologist and an MRI expert, and he's our technical director. He is the director of imaging services at Doctors Imaging, and he's the MRI DTI supervisor. Lynn Keel is an attorney, and she practices forensic law. She's the director of Mindset, and she's our forensic consultant. She's involved with legal support for neuroscience cases. Jason Kirkmans is also an attorney, and he's a forensic expert. He's the adjunct law professor, and he is a neuroscience case integration expert. He and Lynn both are available to any attorney who seeks advice in how to proceed with a particular case. We usually see patients in the chronic stages of post-concussion syndrome. That means low FA. That's usually anywhere between 1 year and 3 years after the incident. However, in the acute or the subacute stages, anywhere from immediately after the incident to approximately 8 or 9 months, you might have FA that is unusually high, or you might have a mixed pattern of high and low. That may be a sign of repair, but that's not proven. It's actually only an hypothesis, so let me explain. So let's talk about how the body might try to repair itself. If you look at the top of this picture, you'll see that there's a bruise to the elbow, and over time, it goes away. It may even completely disappear. So let's look now at the lower left-hand corner, and you'll see the mid-portion of a cervical spine, the neck. And you'll notice that there's multiple levels of disc herniations and degenerations where the discs are narrowed, and there's probably been some herniations here. And you'll see that the body has created osteophytes. That's the deposition of bone and calcification to immobilize this region so it won't be active and cause more pain for the body. It's another repair mechanism in the body. Now look here, you see a perfectly normal blood vessel with good flow and some normal branches. What happens over time if that vessel becomes obstructed and narrowed? These branch vessels start to hook up with one another, and before you know it, when the blood vessel is completely blocked, there's an alternate pathway to get circulation to the areas of the body that need blood and oxygen. So here you have 3 mechanisms of the body trying to repair itself. Well, what about the brain? That's why we're talking about high FA. Can the brain somehow repair itself? I think so, and so do many neuroscientists. We just don't know how this works. But we think that increased FA may represent that effort to repair or accommodate brain damage. In an article by Crowe, Cowie, Peel, and his group from Great Britain, this was published in Neurology in 2013. This is a well-respected journal from the American Academy of Neurology. The conclusion was as follows. Acute, mild, or moderate traumatic brain injury is characterized by increased tissue FA, which represents a clear neurobiological link between cognitive dysfunction and white matter injury after mild to moderate injury. That's an impressive statement, and I think most neuroscientists are working now to try to prove that hypothesis that we had earlier mentioned, that is, the brain repairing itself. And in the next slide, when you hear from Dr. Lipton, he'll mention that as well. I think it's worthwhile listening to Dr. Michael Lipton, who's an MD and PhD at Albert Einstein University in the Mount Sinai Hospital, New York. Dr. Lipton is a pioneer and wrote most of the original literature regarding mild traumatic brain injury and DTI. And he talks about the promise and potential of DTI in neurology in the future. Please listen to him.
What's been pretty extensively shown in trauma, as well as in other diseases, is that when there is pathologic change to the white matter axons, either loss of myelin or loss of actual axon components, that you get a much more random or disorganized movement of water molecules, and that can be an index of the presence of pathology. That is something that is not visible using other techniques. So sort of the key point is that if you look at your kind of most sensitive types of MRI images, things like FLAIR and diffusion-weighted imaging, you won't see anything. So where the white matter looks normal, we can detect very significant abnormalities as a decline or decrease in the FA or fractional anisotropy. But what we can do using this measurement, which we can perform in a human being and we can also perform in an animal, is we can relate the pathologic mechanism to the imaging measure in the animal, and then relate that same imaging measure to the outcome, which is not something you can assess in an animal, because the types of outcomes that matter in people, things like executive function and personality and emotional dysregulation, sleep disorder, are not things you can measure in animal models. So here we have a tremendous opportunity for a translational bridge to really understand what those mechanisms are and how they relate to real-life human outcomes. In this study, we actually are looking at a somewhat different finding, which is that we found in a group of patients who had had concussion or mild traumatic brain injury that not only did we find areas where the FA went down, indicating the presence of that brain injury pathology, but we found extensive areas where it actually went in the other direction. It was almost too good or super normal. And the really interesting thing about our finding is that when we related those brain measurements of that abnormally high anisotropy to outcomes, we found that the higher the anisotropy, the better the outcome. So we were looking at something that doesn't seem to be an indicator of pathology, but seems to be an indicator of something positive or something good, because the more of it you have, the better you do. And while this is a hypothesis at this point, our sense is that this may be a manifestation of neuroplasticity, or a way that the brain may be developing connections to get around or compensate for the loss of connectivity that comes with the actual brain injury pathology itself. So that's really the sort of central finding, and I think that this is a wide open area for us to learn a lot more about the technique and how to apply it to the brain to detect and monitor disease.
Thank you again for listening to this presentation. When you have a head injury case, discuss it with us. There's no charge. Or call me directly, 504-883-3544, or visit our website to learn more, theconcussiongroup.com. There's a lot of information there, particularly if you go under the heading Lawyers. Thanks again for listening to this presentation.